you see, Professor Shrikant was my senior also, and I used to watch him doing fluorescein angiography. And then we were developing fluorescein angiography then there in Allahabad, and laser was not available, so there was xenon arc photocoagulator was available, and we used to do with that. Professor R.N. Mishra, my mentor, Dr. Shrikant, also my mentor. He went to Retina Associates for doing fellowship in retina. So, and I was always in touch with him. So gradually, I was a xerophthalmia man. Gradually, I became laser in the year 1992. Although I passed out in 1983. When this laser came, Professor R. Mishra, as you all can see, is sitting there, and Professor H.K. Tiwari from AIMS, Professor Azad, these two persons used to come, and there was no laser available anywhere in North India. Patients used to come from Calcutta to us. There was no laser available in Lucknow, Varanasi, anywhere laser was not there. So we started doing laser, and those days, we used to simply ask what is the full form of laser. So they used to tell light amplification by stimulated emission of radiation, that we used to ratify. वो उस समय पता नहीं होता था कि ये होता क्या है. So it's basically the gas through which the medium this goes, and it is stimulated, and the energy that is produced, that leads to a kind of laser, and depending on the gas, which the medium that is used, like argon, krypton, based on that we give the name to them. Now, how laser works, that is important to understand. So it basically goes, and the melanin in the retinal pigment epithelium and the hemoglobin, they absorb the laser photocoagulation, that is for the retina that we use. The blue-green laser that was available those days, and we used to hit the, apart from macula, we used to hit all over and do the laser. So it has direct action on the vessels, leading to closure and reduced leakage. This can be done, and it reduces the demand for oxygen. Like in proliferative diabetic retinopathy, you have hypoxia, which leads to formation of neovascularization. And when we do laser photocoagulation, we change the hypoxic areas into anoxic areas, and therefore the demand for oxygen is reduced, and we have regression of the vessels. So that is there. Then there is a third theory, that is the RP activation following photocoagulation injury leads to cytokine production, and this ultimately leads to reduction of VEGF load, and therefore the vascularization becomes less. So this is another thing, and the edema is also then reduced. So this is what I told you. And the quality of the laser is that if you have a single columnated light laser beam, if you throw it from here, it will go up to the moon. But this the light that we see here, that cannot go beyond a certain distance. You cannot see that. So that was used for in the army initially, and gradually it was picked up by the scientists, and this was then used for ophthalmics use also, and variety of things. So based on the medium that we use, I have already discussed this. You can use it, and visible range is there, in which you have a blue-green laser, and this blue-green laser in gray, yellow. In this diagram, you have green and yellow. So this is around 488 and 514 was the wavelength that we used to use. The only problem is that if you go too close to the macula, the heat can dissipate into the fovea and can cause damage to the fovea. Therefore, we have to do laser photocoagulation in the peripheral portion of the macula. Maybe these days we go about 750 micron away from the fovea to do laser photocoagulation. So this is used, and nowadays we have a frequency double YAG laser. YAG laser's frequency that we used for YAG laser capsulotomy and iridotomy is 1016, and half of that is 532, which means that double frequency YAG laser is, again, it's 532 wavelength, which is absorbed by the retinal pigment epithelium, and that is being used these days for laser photocoagulation. So its application in many diseases is there, which will be discussed by the experts very soon. You can use it in diabetic retinopathy, ARMD also it was used, glaucoma, cataract. There are so many uses of lasers that is being done, peripheral iridectomy, then cyclophotocoagulation. All these things are being done by laser photocoagulation, so it becomes non-invasive surgery and become very patient is very happy, and without any incision into the eye you can do several procedures with laser photocoagulation. And there are many. In the past we used to have a laser which had all kinds of wavelengths, so even in that we could select the wavelength and then use that. For cornea the wavelength is different, for retina it's different, for the lens it's different, and femtosecond you have all seen these days has come up again. So there are several indications which gradually they will tell us. There are certain modifications that have come these days, as we were discussing. The problem of the conventional laser that we have been using, even today we are using, that is that when it goes and hits the retinal pigment epithelium, it does not hit the RP only, it goes into the choroid also, and the heat dissipates into the surrounding area in the pigments. So the damage caused because of that, and the spots that are produced cause field defects. So that is the problem. We do PRP, and many a times too much of photocoagulation leads to optic atrophy also in many of the patients. And if you, by the way, hit the macula gets destroyed. So you have to be very careful in using this. Newer modifications are there, which is called semi-automatic laser delivery systems like pattern scanning laser, in which you have 5x5 or 4x4, or depending on the thing that you choose, you can give several shots in one go. So that the time taken by the laser photocoagulation, although it's costlier than the usual one that we have, the time taken to perform the PRP, because you have to go 2000 to 2500 shots, it becomes much less. तो 25-25 शॉट अगर आप लगाएंगे चारों तरफ रेटिना में, तो इन वन गो यू कैन हिट 25 शॉट्स, तो या और भी बढ़ा सकते हैं आप. So based on that you can do pan retinal photocoagulation very fast, and the patient does not have too much of botheration, because in doing laser photocoagulation with what we do, patient gets, after some time he gets tired and he gets pain also, so that becomes slightly problematic. So this Pascal method has come, which can help you. So this is an example of the shots that are given. Equidistant shots go and hit the retina. So the if you post-operatively, post-laser, if you examine the fundus, it looks beautiful more than what you have with the single shot technique that we have around. So that is called Pascal. And then now this micro pulse laser has also come, in which the because there are micro pulses in the pulse form, the laser comes, it comes and it produces heat and then cools off, and then again produces heat, then cools off. Like you have pulse technique in the phacoemulsification, pulses are used there. तो उस तरह से इसमें what you do is that you have less of the heat into the pigment layer of the retina, and therefore the damage caused to the retina is reduced. And it's a sub-threshold micropulse laser treatment is also come, which has less of the damage for grid photocoagulation like and others. It is a very very safe and cheap technique, and it leaves the retinal cells intact. So therefore the damage done is not there, and the field effects also don't appear. So this is the conventional laser wherein the heat is produced and the time taken is more, and here you have the intensity which is produced and then it cools off, then again the intensity, then so the damage caused becomes too less. The complications of as I have already mentioned, need not mention again, and it can lead to macular edema in some of the patients. It can also lead to hemorrhage if you have, by the way, hit the veins, because arteries they get narrow if you hit it, but veins if you directly hit, then it can lead to bleeding there also in some cases. Choroidal effusion can also occur if you are doing too much of shots are being given. Color vision alterations can occur after the laser photocoagulation, and visual field defects we have already discussed. So these things can occur. So this is short pulse laser is 810 nanometer, which is used for doing the treatment for modified grid I have already mentioned. And there is another laser which has come up these days, which is called navigated laser, in which you have a fundus fluorescein angiography available to you, and you know that these are the leaking microaneurysms. Here we have to do laser photocoagulation, so it navigates, and based on that it does the laser photocoagulation. So this allows us to pre-plan the areas with automatic aim is there, so you don't need to bother, so damage cost becomes much less, and in DME it's very useful. So these are some of the changes that have occurred from conventional laser to micropulse laser to Pascal laser to this navigated laser, and further these young specialists and Professor Shrikant will be discussing. Thank you so much.